Hello, everyone. Welcome to the Taking Control of Your Diabetes podcast. I'm Dr. Steve Edelman, and unfortunately, my good friend and colleague and co-host, Dr. Jeremy Pettis, is off in childcare today. I'm sure he's changing a stinky diaper right now as we speak. But as most of you know, we both have type 1 diabetes. We both were diagnosed at age 15, only about 20 plus years apart. We met each other training at UCSD, and we both work at Taking Control of Your Diabetes to educate people with diabetes and their loved ones about all the conditions associated with diabetes and how to live a long and healthy life. Now, today, we have a really, I would say, somber topic. Not necessarily, but when I mention the word pancreatic cancer to anybody that knows anything about it, they know it's a pretty serious condition. And so Dr. David Diamond is a radiation oncologist that treats pancreatic cancer quite frequently. And I'm going to let him introduce himself and tell us something about yourself and how you ended up focusing in on pancreatic cancer.
Sure. Thank you so much, Stephen. And firstly, it's a real delight to be with you, and this is really a lot of fun for me. So as you pointed out, I'm a radiation oncologist. I'm an independent physician, one of the few remaining in Florida in the cancer space. So I have treated folks with cancer for the past 25 years. I've treated some 16,000 cancer patients in my community, which I really consider a tremendous honor. And I've just been very interested in pancreatic cancer for some time. And in addition to my clinical duties in treating folks with pancreatic cancer, for many years, I've been interested in new technologies to try and help screen better for cancer and perhaps yield better outcomes. And I'm particularly interested in those cancers that have no good screening and are particularly lethal, really pancreatic and ovarian. And of course, for today's discussion, pancreatic cancer and diabetes is really an interesting topic.
No, perfect. You just gave a great outline of what we're going to be talking about. And yeah, I talk about pancreatic cancer being a pretty serious condition, but of course, ovarian is another one that, at least as an endocrinologist and trained in internal medicine, is definitely not a good cancer, usually diagnosed way too late. But we can maybe talk about that. So let's open it up and just talk about, I'd like to talk about some general facts and information about pancreatic cancer, and really how it compares to some other common cancers in terms of the incidence and prevalence. Let's just say breast cancer or colon cancer, which both are very common. Please.
Sure. So in the United States, if one excludes the typical skin cancer, the most common cancer in the United States is breast cancer, about 300,000 new cases a year. And shortly behind that would be prostate cancer at about 290,000 cases a year, lung cancer about 250,000 cases a year, colorectal 150,000. And then when you get down just a little bit more, we reach pancreatic cancer, which has an incidence of about 62,000 new cases a year in the United States.
Yeah, that, to me, well, thank you for that, because that really puts things into perspective. And those other cancers that you mentioned, other than maybe ovarian, if caught early, people do much better than pancreatic cancer. So I think the thing that's interesting to the listeners on this call are, what is the relationship between pancreatic cancer and diabetes? And that's one of the most important topics I want to cover today.
Sure. But before I even get to that, one of the big differences between pancreatic cancer and the other ones you mentioned is that we have very good screening for breast cancer. We have excellent screening for cervical cancer. No woman in the United States should die of cervical cancer. We have excellent screening for colorectal cancer. We have nothing for pancreatic cancer. There's no biomarker, there's no imaging test that currently is approved that comes close to being a good screen for pancreatic cancer. And so even though pancreatic cancer is not as common as some of the other cancer types we talked about, the lethality is terrifying. And I mentioned there are about 62,000 new cases diagnosed a year and about 50,000 deaths per year, just to give you a sense of the lethality.
That's almost as many as there are diagnosed.
Yeah, it's
Well,
horrific.
I noticed on some of the things you've written that for the folks listening, in medicine, especially oncology, we always talk about the 5-year survival rate, and that sort of puts everything into perspective. And that probably takes into account all the different types of screening and therapy. But the 5-year survival rate of pancreatic cancer is only 12.8%. And you know the data better than I do, David, but the 5-year survival of like colon cancer, breast cancer, cervical cancer's got to be much higher than that.
Yeah, they're much, much higher. 5-year survivals in breast cancer and so forth are in the 90% range. And the problem with pancreatic cancer is because we have no good screening test, because the signs and the symptoms are so nondescript, most Americans are diagnosed with prostate cancer when it's advanced stage. So the average 5-year survival at all comers, as you pointed out, is only about 12 or 13%, which is horrific. But for those lucky few in which we pick up the disease early, stage 1, that rate may go up to an 80% survival rate at 5 years. So a tremendous difference. So that's why, in my opinion, the future of pancreatic cancer is screening. The treatments that we have are not particularly good. It has to be earlier detection, Steve.
David, that's impressively good to me. Early diagnosis could be your 5-year survival can go up from 12% to 80%. And unfortunately, would you agree with this? By the time you have severe symptoms to bring you to a healthcare professional, you're already past the stage of where you can make a significant impact.
Right. In many cases, when a person comes in with many, many months of weight loss, poor blood sugar control, abdominal pain that's persisting, this person likely has disease that is either unresectable because it involves the nerves or the main vascular trunks of the abdomen, or has spread to other organs. And it's really disheartening as a cancer provider to see folks like this. There's not a lot we can do, unfortunately, in those circumstances.
Yeah. Now, David, other than early diagnosis, for those minority that somehow beat the 5-year survival rate, what other characteristics do those have other than early diagnosis? If there is any.
Well, again, there are a few folks that do have advanced disease that do respond to new treatments. That's on the order of 5 or 10%, particularly with the new immunotherapy agents. But it's a small minority, Steve. It's a small minority.
Well, let's talk now about. Thank you for interjecting those comments because you're the expert, and I have my list bullet points, and we don't have to go in any particular order. But I think once again, the fascinating thing to me, and what I've learned since I started getting involved in the screening aspect, is the relationship between pancreatic cancer and diabetes. And I think this is when people are going to put their ears closer to their microphones or their speakers.
Exactly. Diabetes has an important relationship with several solid cancers: liver cancer, gallbladder cancer, endometrial cancer, kidney cancer. But the strongest relationship by far is this relationship between diabetes, particularly type 2 diabetes, and pancreatic cancer. And it's been the subject of intense investigation. And interestingly enough, it's not really clear what is the cause and the effect. Is it a person who has diabetes, type 2 diabetes, with the insulin resistance, with the chronic inflammation, with the obesity that is commonly associated with type 2 diabetes? Is it those factors causing the pancreatic cancer? Or is it the pancreatic cancer, as the cancer is developing, causing changes in metabolism, producing different hormones and peptides that's actually causative for for the pancreatic cancer. So is it A to B? Is it B to A? Or perhaps it's bidirectional? We really don't know.
Yeah, you just said something that I really had no clue about. I was assuming that when when people get pancreatic cancer, depending if it's in the head or the tail or the main insulin producing beta cells, I believe, are in the head. Once, if a tumor is there and expanding, and you end up destroying those cells. But what you just said was interesting, that pancreatic cancer does lead to secretion of other hormones and substances that may cause elevation in blood sugar. Did I hear you right?
That's exactly it. The greatest association is type 2 diabetes with pancreatic cancer. It seems to be a metabolic and peptide issue more than anything else, more than direct destruction of the head of the pancreas, as you point out, Steve.
Yeah. Well, what are some of those peptides? I take it that you can measure for those once someone is already diagnosed, or that comes from out of...
Not really, not really. Um, and again, this is still a subject of intense investigation. So really, those mechanisms are very poorly understood.
Yeah. And are the presenting symptoms of pancreatic cancer in folks with type 2 diabetes, does it present differently than other patients who do not have diabetes? And what are those presenting symptoms if they're different?
Well, firstly, the most common signs and symptoms of pancreatic cancer are very nondescript. Asthenia, meaning just not feeling very well. Weight loss, which in fact in many folks is a welcomed happenstance. Vague abdominal pain that is poorly localized. And then, of course, as we've been discussing, changes in glycemic control. In fact, the statistics are really quite powerful. The incidence of pancreatic cancer in folks with newly diagnosed type 2 diabetes is 6 to 8-fold higher than folks who don't have type 2 diabetes. So 6 to 8-fold increase. It's remarkable. Another statistic, another way to look at it, if you look at all folks with newly diagnosed type 2 diabetes, within 3 years of their diagnosis, 1% will develop pancreatic cancer. So this is a very, very high risk population. And I would argue that those risks are similar, if not higher, than the risks that we see in folks undergoing standard colonoscopy at age 50 years and beyond, or for folks with a history of tobacco smoking who are getting low-dose CT. So the incidence is very, very high in this population, Steve.
Yeah, well, you mentioned 1%, but I don't know if our listeners know that every day in America, over 6,000 people are diagnosed with type 2 diabetes. So the number is huge. Now, why is it that the highest risk people are newly diagnosed over the age of 50? Type 2 diabetes is now occurring in kids, for God's sake, because of the obesity that we're seeing and the strong family inheritance of Caucasians, different ethnic groups that have a high risk of type 2 diabetes.
Well, that's a great point. The median or the average age of diagnosis of pancreatic cancer in the United States is 70 years old. But
70.
70. But I bet because of the changes you're just discussing, we're going to see that that number coming down. I wouldn't be surprised if we see a trend 65, 60, as there is an explosion of type 2 diabetes in younger people. I'm sure you see in your clinic young people that you never would have seen 25 years ago with type 2 diabetes.
What about people with type 1?
Well, again, type 1 diabetes, there's not that causal association, meaning we don't think it's the type 1 diabetes causing pancreatic cancer. Certainly, there are folks with advanced pancreatic tumors that have destruction of the islet cells and develop type 1 diabetes, but that causality is not the same as what we're seeing between type 2 diabetes and pancreatic cancer.
Yeah, you know what? I don't think too many physicians or healthcare professionals know that information, what we just talked about. And that's why it's so good that you're on the podcast, because for all the folks listening who have type 2 or have a family member with type 2, it's not a bad thing to mention it to their healthcare professional and potentially get screened, which we'll get to in a second. But getting back to the relationship and how these folks present, I could really see it taking longer than it should for people to screen because, one, people with type 2 are typically heavy. They typically have insulin resistance, and maybe they've been put on a GLP-1 receptor agonist like Ozempic or Mounjaro, and they have a little bit of discomfort, or even metformin, which is a common drug, can cause that. And that may throw off, any healthcare professional, may even throw off the person living with diabetes to even complain about it. Like you said.
Or maybe they have other health conditions and they're on steroids, for example. That's masking what's going on because the steroids themselves are causing changes in glucose levels.
Yeah. So, David, we talk about the newly diagnosed type 2s. What is the time frame? Is a year after the diagnosis, does that put you in a safer zone?
I'm not sure I understand what you're saying.
What I'm saying is, we say newly diagnosed type 2s. What is newly diagnosed? Is it within 1 year of the official diagnosis, or 2 years, or 5 years from the diagnosis?
For most folks studying this particular issue, we're talking 3 years from the time of initial diagnosis. That would be our time frame. Anyone within 3 years of the initial diagnosis, we consider a newly diagnosed diabetic.
Got it. That's exactly what I was asking. So let's talk about screening now. I'll give the microphone over to you. Let's talk about screening for pancreatic cancer. What other than just picking up someone with symptoms and educating people, what else could they do? I know it's not that hereditary. I know Jimmy Carter, everyone in his family almost everyone passed away from pancreatic cancer. Talk about the familial tendency, and that may increase someone's awareness to get screened. And then we'll talk about the different screening opportunities.
Right. So first thing first, as of today, there is no screening FDA approved in the United States for pancreatic cancer. There's not one imaging test. There's not one blood test, not one molecular test. Ultrasound, CT, MRI, different blood tests, none of these have been shown to be useful in a screening setting. In terms of risk stratification, there are certain folks that do have higher risks of developing pancreatic cancer. There are individuals with hereditary pancreatitis, for example, Peutz-Jeghers syndrome, which is a particular type of genetic syndrome, individuals with pancreatic cysts of various causes, folks with certain genetic mutations such as BRCA mutations. Those are all high risk folks from a familial point of view, but that still represents a minority of folks with newly diagnosed pancreatic cancer. And again, the signs and the symptoms are so nondescript that unless the clinician is really astute and is thinking about it, as we always say, if you don't think about the diagnosis, you're never going to make the diagnosis. You have to think about it.
Yeah, well, that list are a list of conditions that most people don't see or know about, including physicians. Of course, we know about pancreatitis and I think you said pancreatic cysts, things like that. But some of those gene abnormalities. Do you know what the story was with Jimmy Carter's family by chance?
No, I don't. Tell me the story.
Well, I don't know the cause, but I do know that he had 4 or 5 mostly first degree relatives. And
I know Jimmy Carter had melanoma, and there is actually an association between pancreatic cancer and melanoma. Perhaps that's where you're going.
Well, I really don't know the cause, but I thought it was interesting that, and apparently they were saying that he was being screened every year aggressively for pancreatic cancer. He's still alive and has not developed pancreatic cancer, but I think some of those screening techniques could be not really helpful, as you just mentioned. Well, what is available for screening?
So right now, the greatest excitement are some of these new liquid biopsies. And when I use the term liquid biopsy, we're talking about blood tests. And these new generation of blood tests are really quite fascinating. In one particular test developed by a company called ClearNote, what's going on is we're actually looking at cell-free DNA. So a person has a cancer. The cancer is constantly releasing DNA into the bloodstream. And these tests can actually pick up not just fragments of circulating cell-free DNA, but the tests are designed to look at how the DNA is chemically modified, a signature, if you will, and using artificial intelligence to go and identify cancer based upon these fragments with these particular signatures of chemical modification. Almost like if one is trying to break an enemy's code, doing some sort of signal analysis on letter frequencies. You're looking for particular signals of how the DNA is chemically modified. It's really quite amazing.
So these pancreatic cancer cells they break, and they release a particular sequence, the DNA sequence, and that is specific for pancreatic cancer. They can pick up in this test.
But even more than the sequence is how those sequences are chemically modified. The DNA, every somatic cell in our body has the same sequence. What determines active biology is how the DNA is chemically modified. That's what causes one cell to become a hair cell and one cell to become a neuron. Same thing with cancer. Most of the active biology is not the sequence, it's how the DNA is chemically modified.
I see.
That's the frontier in medicine.
Yeah, no, that's fascinating. So this liquid biopsy, as you call it, can you get it with a drop of blood on a special card and you mail in, or do you need to get it at a laboratory that specifically has this test? How would someone get this test if they're concerned?
So right now, the test is commercially available. It's from a company called ClearNote Health out of San Diego. It's just a simple blood draw. And as of right now, the published sensitivity, meaning the likelihood of being able to find a pancreatic cancer at an early stage in a screening population, is approaching 70%. So being able to detect it, 70% sensitivity is incredible, plus a specificity of about 96%. So when you're looking at a screening test, you want a very good sensitivity so you're not missing cancers, but also you don't want to have false positives. You don't want to, God forbid, say, Steve, I'm sorry, it looks like you have pancreatic cancer, and your world goes upside down, only to find out that it was a mistake, it was wrong. And that, of course, is highly distressing and problematic. So you want a test that has both good sensitivity and excellent specificity as well.
Yeah, those are, you explain those mathematical terms pretty well, because we use those terms all the time, sensitivity and specificity. Well, now, but can you go to Quest if your doctor writes a prescription? I want to give folks specifics. And before I finish, before you answer, folks could also go to the TCOID website. We recently had a news letter article about this whole situation, and spent quite a bit of time talking about pancreatic cancer screening, including the ClearNote test.
So today, a patient with, for example, newly diagnosed type 2 diabetes or other risk factors can go to his primary physician or her endocrinologist and request the test. The physician will fill out the requisition order. A patient will be sent to, let's say, a Quest laboratory. The blood will be drawn, sent off, and come back in 2 weeks.
Yeah, that's probably the longest 2 weeks of people's lives. But, if they're concerned about it. And what is the name of the test?
It's called Advantech by ClearNote Health. Advantech is the name of the test.
Yeah, and there's no other screenings out there, so people couldn't get confused with anything else?
No, that's the only test by that name, and the only test commercially available for pancreatic cancer that I'm aware of.
Okay. No, that's good information, and we'll put that information on our website as well. So, and what happens if it's positive? You don't know all the details, but what is done by healthcare professionals that could prolong someone's life and increase the 5-year survival rate?
Right. So when the test is reported, it's very simple. It's either a yes or a no, signal detected or not detected. If the signal is detected, that is the reflex for the patient to get a very thorough evaluation. Typically, this would include an MRI of the abdomen and the pancreas, and a thorough medical evaluation. And at this point, we're no longer really looking at doing this imaging as a general screening, but really a focused evaluation with the person presumed to have pancreatic cancer until proven otherwise.
Got it. And the MRI specifically of the pancreas, looking for any abnormalities that they can go from. And then if that's positive, I'm sure they're going to do a metastatic workup as well. And then they can institute therapy, whether that's chemotherapy or radiation.
Or hopefully it's even earlier when it can be surgically removed. That's right. The best of the best. That's the gold standard, to do a surgical extirpation and for stage 1 pancreatic cancer and save that person's life in most cases.
Yeah, that's encouraging. I say that as I have a very close friend from medical school who's very ill from pancreatic cancer. And by the time they got it diagnosed, it was too big to operate on. It was near some important vessel. And he's had chemotherapy and radiation, and it is not fun. Mm-hmm. I worry about him, and hopefully he does the best that he can do. Well, gosh, we've talked a lot about this serious condition, but I am excited about the fact that if people are knowledgeable, everyone with newly diagnosed type 2 and newly diagnosed up to 3 years, and who knows what that exact number is, they can actually, if they're concerned, and especially if they have some of those other risk factors you mentioned, get screened. And it's just a simple blood test. Liquid biopsy sounds a lot more serious than a blood test, but you're a radiation oncologist. Yeah. Liquid biopsy. That sounds like a drink at a bar. But in any case.
But again, the future, Steve, I think would be, hopefully the time will be soon that throughout the United States, there's a new treatment guideline. And just as folks with newly diagnosed type 2 diabetes are getting comprehensive education, perhaps weight loss counseling, fundal exams, that perhaps there'll be a time very soon that this type of test is incorporated as part of the treatment management so that we're not missing these patients. So, perhaps the major health plans, the VA health system, and so forth, that soon this type of testing can be incorporated in a standard fashion. And just like anything else, if you do it each and every time, you don't miss it.
Yeah, and I would love to see this eventually on the American Diabetes Association treatment algorithm. They put out standards of care every year, as you know, and there's a lot of things we screen for: blood pressure, lipids, fatty liver now. So this could be something that could be added to the general guidelines, and then people will start being aware. So, well, with that, I want to thank you so much. Is there any last words you'd like to say before we close it out?
No, I appreciate this opportunity, and I really appreciate the tremendous work that you're doing, Steve, for the diabetes community. It's tremendous. So congratulations.
Well, you're very kind, and thank you for all those folks that you have helped through the years. If you're going to get radiation therapy, you want to go to someone that really loves what they do, knowledgeable, and that certainly seems like you're the guy for that. And remind people that remember to like us and to visit us on TikTok, LinkedIn, Facebook, YouTube, and Instagram. Wow. My younger kids would be so impressed with that. And once again, we have a really information-packed website. Really only one article on pancreatic cancer and diabetes, which was recently put out, which I believe has information on ClearNote, which is good, and those other cancers that are associated with diabetes, as you mentioned briefly in the beginning. So with that, David, thank you so much. I hope to meet you face-to-face someday.
Thank you.